I would like to introduce Dr. Suri. Dr. Suri from Taiwan. Again, Dr. Su Airi, he's the cardiovascular surgeon from, Kaohsiung Medical University. Today, he's going to talk about the interesting case, number 4, wide neck AAA. Dr. Lee, please. Yeah.
Okay, good afternoon, everyone. Good afternoon to Chairman, Mr. Chairman. And I'm Daniel Su, and I'm from Taiwan. And it's an honor to present here. Today, I'm going to share our experience of wide neck and short neck AAA. There's 2 cases of our experience. The first case is a 71-year-old male. He had a symptomatic AAA for 4 months. There were no abdominal pain and no tenderness of the abdominal area. We found his aneurysm by accident, and he had history of hypertension, HIVD, and dyslipidemia. He had his intervention in last year, November. And this is his pre-op CT survey. As you can see, he had an aneurysm with largest diameter about 5.7 centimeters and a conical neck. There were no rupture signs and little calcified at his bilateral iliac arteries. Coronal view present conical aneurysm. And for his pre-op plan, his aneurysm had a wide neck and around 28 millimeters with short landing zone, less than 6 millimeters. But luckily, there were no thrombus or calcification around his neck. And we use Halifax to enforce and prevent late dilatations. In the end, we choose Gore CTEC, main body size 31 millimeters, and right leg 18 millimeters, oversized about 20%. And left leg size 16 millimeters, also oversized 20%. And these were intra-op footages. The first one showed initial sizing and marking renal arteries. And this one is the footage show we applied Halifax into stent and outer wall by rotating and deflecting the guide sheets to appropriate orientation. And the second image you show is the final angiogram, showed no immediate complication of the interventions. There were no endoleak and no excess injuries in the end of intervention. And then 3 months follow-up images show no other leg complication and no progression of the aneurysm and no migration of stent graft, and there's no endoleak. From coronal view, and so this case is a very lucky case. Then there was no endoleak, no progression of the aneurysm, and stable size of the aneurysm sac, and no migration of the stent graft. And the second case is a 179-year-old male. He had personal history of hypertension and COPD and prostate cancer. We found his aneurysm during survey his prostate cancer. Well, we had waited until completed chemotherapy cycle, and under relative stable condition, he received intervention of his AAA this year. Largest diameter is about 5.8 centimeters. And this is his pre-op CT survey. And you can see there's a thrombus formation around his neck area. And coronal view. So for his pre-op plan, In this case, we choose to use a Medtronic stent. CT shows thrombus formation, but no more than 2 millimeters around the neck, and the neck length is around 7 millimeters. Therefore, we plan to use the helifix as well. So in this case, we choose 25 millimeters in main body size, and both leg 20 millimeters in diameters, and endo anchors for his short neck aneurysm. And this is his intra-op footage. The first one is initial sizing imaging. And the second one is the one we applied endo anchors. So the final angiography shows no immediate type 1A or 1B endoleak. But however, during the post-op follow-up, we had found one endoleak at left leg stent graft. There we go here. There. It looks like a type 3 or type 2 endoleak. And the coronal view. So in the end, we have confirmed that it's a one type 2 endoleak lesion from IMA. There's a one feeding vessel here, very small one. There. But there's no progression of the aneurysm sac during the 3rd month follow-up. So we will keep following this case until the 6 months after surgery. And we hope it will resolve by itself. So in summary, hostile neck including neck diameter, large neck diameter, or the short diameter, short neck less than 10 millimeters, or neck angulation, or the presence of thrombus or calcification. These factors will associate with poor result in terms of aneurysm exclusion. So in these 2 cases, we choose to use endo anchor to prevent late dilatation and migration due to the large and short size neck. Luckily, there were no such 1A endoleak to happen recently. And just like Dr. Wang says before, we don't like to treat patients once and once again. So we kind of prevent late dilatation to use endo anchors. Thank you.
Thank you very much, Dr. Su. Very interesting 2 cases. I have one question. For the second case, you make a measurement, the neck length is 11 mm, and that's right, the planning and sizing for the second case.
Yeah.
So could you show slide again? Yeah. Yes, yeah. As you can see, yeah. The neck length is 11 mm and the not severe neck angulation, no conical neck. I think that this one is the IFU of the endurance stent graft. So in this case, you perform primary treatment for aortic stent graft, that's right? No 1A endoleak?
No.
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 Yeah.
No immediate 1A endoleak.
What is the reason? That's because this one is along with the instruction for use from the endurance stent graft. Yeah.
You mean
yeah.
why we choose to use endurance?
Yes, yeah. Why you choose the endo anchor for primary treatment in this case?
Oh, in this case, I think both Gore or Medtronic products will go along with this case, but we kind of choose each one and for each cases if it both apply to the cases. So we will take turns Yeah.
Okay. Dr. Vitawat or Dr. Wang, you have any comment or any question? Yeah. So right now, how many cases you perform a primary treatment with the endoanchor, and what are the indications?
Not much. In my personal experience, only like 3 or 4. Yeah. So until now, I haven't met such complication like Dr. Wang applied before. You push the outer wall away from the stent graft. So I'm just lucky until now.
Thank you.